let's move on now, and we'll talk about how we treat newly diagnosed symptomatic patients. So these are patients who clearly need therapy. And maybe, Saad, we'll start with you. What factors do you consider when determining the most appropriate upfront therapy for your... Let's start with the transplant-eligible younger patients.
Sure. So the general approach for the transplant-eligible patients is a triplet regimen across the board.
Triplet of what?
Of lenalidomide, bortezomib, dexamethasone. There are certain situations where you need therapy quickly. For example, a patient who's presenting with renal insufficiency, getting admitted to the hospital, and that's how they're being diagnosed, where you might reach for a regimen that includes bortezomib, cyclophosphamide, and dexamethasone to begin with.
And who, just for patients with renal failure, for example?
Yes, yes.
Yeah.
So, generally the goal is to try to induce cytoreduction fairly quickly and try to get them to as best a response as you can before taking them to a transplant.
So this combination of RVD seems to have become a sort of de facto standard in North America, at least. Mm-hmm. Anybody using anything different in their newly diagnosed patients, outside of trials, just in routine practice?
Well, I think in the context of triplets, certainly I completely agree with Saad. The question then becomes the 4-drug regimens and what might you use. Right. Mm-hmm. And I personally, we've been participating in a variety of studies, and actually with partnership with Sagar, looking at the addition of HDACs to the 3-drug platform. Mm-hmm. And for example, now with the approval of panabinostat, the use of panabinostat with RVD after Jatin Shah's very important work, and prior to that, Sagar and Jonathan's work with RVD voronostat. We're comfortable deploying HDACs earlier off protocol in patients who we think might be at higher risk. And
there are some new oral drugs that can be considered. I think you've got some experience, Amrita, with ixazomib and used with lenalidomide, dexamethasone. Can you speak to that a little bit?
Right, and I mean, certainly you're right. Oral drugs are very attractive to patients, especially early in the stage of their disease. It's been well tolerated. For example, the ixazomib, lenalidomide, dexamethasone regimen has induced deep remissions, long responses. I have someone who's been on it for 5 years right now. Just to Paul's point, though, in terms of additional agents, I do want to mention immunotherapy as well in the early upfront setting.
Such as what?
Well, Saad has a trial that we participated in of adding elotuzumab to an RVD backbone for high-risk patients. And certainly we are opening a trial with the addition of daratumumab to an RVD backbone. So I think when the immune system is more intact is a good time to intervene with these agents.
These are mostly clinical trials at this point, though I think it's fair to emphasize. Before we leave the triplets, so is Emory using, I'm assuming that most people would reserve the all-oral regimen like ixazomib for a more elderly population, just so we don't neglect that group of patients. What would you treat an elderly patient with today that came in with newly diagnosed myeloma?
Yeah, I mean, I think what everybody is sort of summarizing is the idea that an IMiD PI represents probably the best backbone. And I think in the US, the IMiD would be Len, and in the PI question really depends.